Okay, good morning, everybody. It's Sebastiano from Nova Via here, and we are recording again another Nova Talk. This morning, we have the pleasure to be with Nicol Van Dyk. Nicol has been involved with us in running courses on muscle injuries management. So, first of all, how are you doing today?
Yeah, thank you very much for having me. Interesting times we're experiencing now, and with everybody in their home environments now. So great to have the opportunity to chat with you today.
Perfect. Yeah, it is a weird time, but what we decided to do with Nova Via was to produce sort of a new format. A lot of content are generated, online content are generated in these days, and the idea with the Nova Talk was to possibly produce qualitative contents, not just on clinical topics, but also something that is more broad in terms of what can be stimulated out of this. And so that's why we're here today. So the topic with Nicol today is talking about, let's start from the term injury prevention. We would probably shift towards another terminology during this chat. We will see. So first of all, Nicol has a PhD, successfully completed a PhD in relation to a risk factor for hamstring injuries in football players and professional players, and is now moved. So his career moved on now. And also physically, he was in Aspetar, Qatar. Now is no longer there. So he's in Ireland and covering a new role in injury surveillance. So, and also obviously you run research for them. So why don't you tell us a little bit more about that? What is that you do in these days?
Sure. Yeah. No, it's been an exciting times for us. I also became a dad 2 months ago. That's probably the biggest change. But I was fortunate to be involved at Aspetar, an orthopedics and sports medicine hospital in Doha, Qatar, for the last 7 years. And during that time there, working as a physiotherapist, I was also able to complete my PhD, as you said. So I ended up being part of our injury prevention team, and now got the opportunity to join the Irish Rugby Football Union as the Injury Surveillance and Medical Research Officer. And so I think we are now at a time where we realize the value of epidemiological data. You know, we suddenly realize that it's important to understand how big the problem is, and then also what we can do about it, and the best way to use our resources to address any health problem. So from a sports point of view, that's what we're doing with our injury surveillance efforts. And I have to give the RFU credit for an innovative approach to this and creating this role where we're really trying to establish a data foundation for the clinical decisions we make. And there will always be a decision. There will always be a decision-making process. But we want to try and inform that process as best we can with latest research and up-to-date evidence. And that's the role at the moment. We're just starting to put many of our mechanisms in place, but really excited about the future and working with the IRFU.
Okay, so it's actually interesting, this thing. Also in professional sports, not a lot of teams or organizations are doing this. A lot of people are thinking of also implementing these programs. So basically, it's all about making sure that the money that are invested by the teams are worth. I mean, in the end, if you can pay someone like you or someone else in the other situations that is able to reduce the time that the players have to be sidelined, well, it means the wages, so the money that the clubs are spending are actually, I mean, worth it. If the player is out less time, it's just much better. So good.
Yeah, I mean, absolutely. It's all about performance, right? At an elite level, but I would argue, as a very amateur athlete myself, I want to be able to ride my bike, to do the events that I enter, and to the best of my ability. So our job really is to protect our performance while we minimize the risk of injury. And of course, it's a team effort. We have amazing data scientists. We have an amazing athletic performance department and a host of other medical staff within the provinces and at a central level. So it's a team effort. But I think it's valuable to have, and that's where physiotherapy or clinical professions come in, or perspective around some of these aspects may be valuable and contribute to these efforts.
So going ahead with this chat, at the beginning we introduced the fact that it might be, we were talking about injury prevention, but also probably we should talk about risk management. So we'll get there through our chat. Let's start from the past. So what have we learned from the last, let's say, the past 30 years in terms of injury prevention?
Yeah, I mean, it's amazing how far we've come. Although I think a lot of the core principles have really been solidified. And maybe I can start with, to get us all on the same page, what do we mean by prevention? If we're saying injury prevention, and you mentioned it there, maybe there's a shift towards risk management. But, if we think about prevention in other areas of medicine, the most effective form of prevention often is removing the exposure to the thing that puts you at risk. So if you're a smoker, and we know that smoking has a big association with lung cancer, we tell everybody to stop smoking, which makes sense, right? But in sport and in healthy lifestyles, we don't actually do that. We do the opposite. We encourage you to engage with the thing that puts you at risk of injury. So by comparison, it would be to say, well, we'll try and figure out exactly how many cigarettes you can smoke before it's a problem. Yeah. Now, of course, that's almost impossible to do. So we have a different approach, I think, to injury prevention in sports and exercise medicine, where we really are ultimately trying to perform risk management. Now, if you think about the past, I think the idea or the understanding around prevention became very important, or was highlighted when Willem van Mechelen introduced the sports injury model back in 1992, I think. Now, that was find out how big the problem is. So like I just said, that's part of why epidemiology is so important. Understand the risks or the causes of that. Find something you can do about that. And then we test whether we've made the problem a little bit smaller. Mm-hmm. Now, at the same time, Willem Uwisse came up with an injury etiology model. That's more a causation model. So Willem's model is based on research. The causation model identified these risk factors might be intrinsic, so stuff that I have, my strength, my ability to produce power, previous injuries, and then external factors, the environment I perform in, my workload, and then that was then updated a little bit later into the dynamic recursive model, where we understand that these factors, of course, change, and you come out of your injury, you come out of your risk, and you are again produced, you're back in the cycle where we try and mitigate risk and protect your performance. Roald Barr and Trond Krosshaug also emphasized the importance of the injury mechanism. So understanding that there's a mechanism by which we get injured. I think Caroline Finch then moved us forward by introducing an implementation side of this. So if we're going to do something about our injury risk, what do we do? And what are the factors that are important to making that introduction or that implementation successful? So the culture you're moving in, the adherence or the compliance with the programs, understanding the environment or the context that you're performing that in. So that's all really important. And then I think the latest advance has been through a better understanding of the complexity behind injuries and how they occur. So Natalia Bittencourt wrote a really great paper a while ago on complexity theory and how that influences sports and exercise medicine. So now we appreciate that there are, and we have done for a while, there are multiple factors, multiple things that are important for an event to occur. And we need to try and incorporate, understand that complexity when we're making decisions about our interventions.
Yeah, so let's say it looks way more complex than it probably used to look in the past. So considering this and talking about screening in our everyday clinical practice, so can we still identify athletes at risk with screening?
So I think that was another really important piece of work. So Roald Barr wrote a great paper in BJSM on why screening factors won't predict who will get injured, and they probably never will. So I think there we have to think about prediction, right? So if we're trying to pick out the individual athlete that will definitely tear his hamstring in this football season, that is virtually impossible. I think it's really hard to predict that because there are so many things that influence that. But perhaps we can still stratify risk. Perhaps we can still understand the different components that an athlete may present with that puts him at slightly elevated risk. Now, the decision of whether that player plays or not is still going to just incorporate that information. So there are still other factors that will definitely play a role in what kind of risk we're willing to deal with. If it's the final of the World Cup, I know I'll play, and I'm sure most football players will say, you know what, I'm okay with taking that chance. If it's the first game of the season and I've just signed a big contract and, I'm going to be the captain of this team, I'm 20 years old, the club has spent a lot of money on me, maybe we'll let him rest the first season. But those are difficult decisions, and by estimating, by understanding how risk changes, we are able to then better stratify what we do and how we do that with our players.
So, not easy question, I know, but let's see, summarizing, because there are different levels, right? In professional sports, physical therapists, they work in a team. So obviously it's a team job, and it's easier, maybe. Well, it depends from the perspective, but anyway. But in everyday clinical practice, when you work in your own clinic or anyway with patients, it is just you. Yes, you can be in contact with the doctor, but anyway, it is different. The setting is different. What would you say is the PT, the physical therapist, role in PT, in injury prevention, or risk management?
Yeah, so I think the physiotherapist has an important role to play. If we think about injury prevention as a risk management program, I think the first thing we want to know is how prevalent, what's the risk of having an injury in the league that you're competing in, for instance, in the team that I'm in. And then you have a benchmark. You have kind of a place to start from, a baseline, if you will, for risk. And then you're probably going to think about what you're going to do in that season. Now, in this season, it's a complete different scenario. You suddenly have to think, and I mean, almost every professional team in the world has to think about how they're going to prepare the players coming out of this period to get them ready to compete. How much time do we need? Because you won't have a normal preseason now. So how much time do you need now, and what are the risks associated with that? If I ramp up your fitness too quickly, what will that mean? If I take too long, you'll be undercooked. You won't be ready. So there's some interesting questions, but that's what we want to do. So step 2 would be assessing what you're going to do in that year. And then step 3, I think, is where we play a very important role. So if we move away from testing for one single risk factor at one time in the year and implement more of a monitoring system, I think that could be really, really important. So you're not looking for a factor, but perhaps a pattern. So for a player's strength, if they are normally at a certain level but suddenly drop out, there may be good reasons for that. But if there isn't, we want to investigate. So I think physiotherapists are generally, together with our strength and conditioning colleagues, ensure that the folks that spend most time with the athletes. So I think it's important for us to move away from these isolated testing to a monitoring system. And then the 4th step would be, what do we do about it? If we think about prevention, probably three things we do. So if we think about primary prevention, that's like a vaccine, right? Which I know is a term we all have heard a lot about as well these days. But if you think about, let's say, hamstring injuries and the Nordic hamstring exercise, at a group level, we know there's been really big effect showing that it's effective in reducing your number of injuries. So let's say the Nordic hamstring exercise is an exercise we feel everybody in the team has to do. Of course, there are athletes who will respond differently, but as a rule, that's what we do at a group level. And then we think about secondary prevention. So secondary prevention might be where you identify certain aspects where athletes are either not injured yet or have a little niggle. So they've had a drop in strength. You work on those things with components, neuromuscular control, whatever it may be, to improve before they go back to full competition or training again. So that allows us to mitigate the risk associated with those elements that we pick up. And it's hard to say what the rules are for those. Usually you have to really think about what that is in your own team. And then I would say the third level is tertiary prevention. So physios play the biggest role here. And we've shown in Aspetar that it's funny, it's just kind of how it happened. And in Qatar, it's a really unique environment. So all the players at some stage were seen at Aspetar for their hamstring rehabilitation. Mm-hmm. So when we did our first investigation, we looked at the first 4 years. Previous injury was a risk factor associated with having an hamstring injury again, which we all know it's a very strong risk factor, perhaps the strongest risk factor. And then after a couple of years, that disappeared. So when we did another investigation, looked at previous injury again, suddenly it wasn't associated anymore. Now, there are other things that could play a role, but one thing that I know is that we introduced 2 randomized controlled trials. Now, that means everybody, whether you were in the intervention or the control part of the study, got a really, really good hamstring program. And that knowledge was shared across our system. So I think, to me at least, and this is an interpretation of what happened, but I think it demonstrates that if we do a really good job with our rehabilitation, we can actually drive down the risk of another or follow-up injury. So that's incredibly powerful for us. But I would say the caveat is have to do a good job. You have to make sure you have criteria-based, outcome measurable rehabilitation. And I think that's where we can play a really, really important role as well.
Yeah, you anticipated a question actually, and it was exactly in relation to this, because what we showed in Aspetar was this. We know now, as you said, previous injury is the risk factor number 1 for further injuries. And if we think about other, rather than muscular injuries, after ACL reconstruction or whatever, the qualitative physios. So what we do, the playing our role in implementing qualitative physical therapy program, it plays such a strong role. And this is not very well measured yet in terms of research. I mean, we do know that people get injured, and then we have the stats after 2 years, even long term, 30% injury, like they got injured again. So we are all focused on return to sport, what we do, how we test people, but nobody's really talking. Well, yes, someone is talking, but the focus is not about what we do with them, the qualitative work that we should do. And we had many, many interesting papers in the past, also Claire Arden and colleagues published on how poor is, for example, for ACL, this is it's not muscular injury, but how poor might be what we do worldwide. And so it's such a diffuse injury, for example, ACL tears, and we are just doing not a good job. And then they come back, they get injured, and we have all the epidemiological papers, but these are data that we kind of contribute to produce, right? So that's what I like what you said. Very important what we do.
So that's an important point. So if we think about football, we know that hamstring injuries is the number 1 injury in football, right? It's by far the most common injury we see almost in every league around the world. But it wasn't always. You know what used to be the most common injury in football? And I mean, that won't be a surprise. It was common in very many sports, was ankle sprains. So ankle sprains used to be the most common injury in football because we probably had lower quality pitches. We had less information around the boots that the players wear, but also we were still trying to figure out good rehabilitation programs. So in volleyball in Norway, they showed the same thing. Once we were able to introduce really good rehab, the risk associated with a previous injury disappeared. And in general, in football now, we've shown that we've bumped the number 1 injury off its spot and replaced it with a different one, maybe because the game has changed as well, right? It's more high-speed run, perhaps higher levels of competition across football as well. So we're definitely able to influence that. not only physiotherapy, I think as a fraternity we are, but then certainly the rehabilitation part of that is absolutely vital. And I think, while we're talking about this, that's another really important thing we're experiencing now. I mean, we've never seen so many people work together on a global level to solve the pandemic at the moment. And I hope that those lessons also transfers over to other fields, including ours. We really need to work together as a sport and exercise medicine group, as a field. The only way we move this forward is if we share our information, share our processes. And there's so much clinical knowledge, experience that comes into treating injuries, that the more we share those, the easier and the better it will be for everyone in general. And we'll all benefit from that process.
Yeah, and we already know this. It's just a matter of implementing it, right? I mean, these are informations we already have. So
yeah, I mean, but exactly what you're doing with this Nova Talks, it's about sharing our information. Of course, there are expertise, and we want to be able to value that too. But certainly, these types of channels, whether it's podcasts or interviews or and I think maybe even make some of your practice available. It's absolutely vital going forward. And I think it will be the new normal. I hope that we will be encouraged now to share more openly what we do, and be open to criticism, to say, hey, you know what, that I like the way you do that. That might work a little better.
So this was not planned. We had a quick chat before recording this, but I think it's interesting. So considering, again, the multidisciplinary nature of this job, so doctors, physios, athletic trainers, and also coaches and athletes as well, because in the end, they are the crucial part of it, right? So the athletes. So let's talk a little bit about load management, because this is something in between physios and athletic trainers, strength conditioning experts. So, and a lot of talking about this, obviously. So in a very brief way, what would you say in terms of load management and the role that it plays? We all know it plays a big role, but in risk management or injury prevention, yeah, let's say that way.
Yeah, well, I think we've there's a big debate about this at the moment, and rightly. Folks have criticized some of the processes that have happened, right? But I think it's important to remember that it's not long ago where we had no inkling about load and how it relates to injury. Maybe you could argue the endurance sports guys, they've been doing this for a while, right? Because that's a way more prevalent aspect of training for endurance sports. You're always kind of pushing that boundary between performance and braking. And we see it in endurance competitions, the Tour de France, triathlons at the Ironman, where they push the boundaries so hard, and sometimes they get it a little wrong. So in team sports and in for sure, we've suddenly realized, and it's largely due to the initial work by Roger Bannister and then also Tim Gabbett later on. Maybe in the past 20 years, we've really applied this model to injuries and to understand the relationship with injury. So to my mind, there's a few experiments where we haven't done yet. Again, there's so much variability, so many different components that play a role. We are finding a lot of different results, a lot of different ways to achieve those results. And at the moment, there is not a clear rule, I would say. But what we do want to keep in mind is the acute load that you're doing. So how much are you doing this week compared to what you've done in the past, right? I think that still the fatigue and fitness elements are still important. From a physiotherapy point of view, especially when looking at injuries, I think it's vital that we remember, if you're doing rehab, you're still doing, in the words of Paul Glasgow, training in the presence of injury. So what we want is the same thing we want when we're training. So when we're training, we want stimulus to drive adaptation, so you're stronger, faster, more powerful, or have more control. And of course, the usual caveats, right? You have to have good technique. You have to understand how they explain. All those still apply. Now, in training or in rehab, we want to have stimulus to drive adaptation of the healing tissue. Same thing, right? So we still want to make sure that you're loaded. And then when the injury has started to resolve, you want to expose you to enough training that you're ready to compete. And that, I think, is an absolutely vital part of what we're doing. But there won't be any easy answers. I think we even in this space, we have to appreciate that it's a complex system. And I think from a research point of view, we really still need large experiments to understand it better.
Yeah, the important thing for me in asking you this was what you just said. I mean, we didn't care. We didn't even consider the whole thing until, I would say, 10 years ago. So whether there are no rules, and maybe we will never land in having a precise indication of what we have to do, at least we are now considering the loading patterns and the load itself. So a lot of people are now concentrating on this and studying and publishing, and this is a positive thing. And when there is a lot of discussion around a topic that is relevant, it's anyway positive. So let's see where we go with this. But anyway, at least we are now considering such an important factor.
Yeah, and I think it reinforces the importance of working together. The athletic performance guys, the strength and conditioning fraternity, that they understand that principle much better, and it was a revelation to us when we applied it to injury risk. So performance, that's I think the important thing also to consider is performance and injury are the two sides that we're looking at. It's no good. I can prevent all the hamstring injuries we see in elite football. If I put a speed limit on the football games, it would just be terrible performance. I probably won't buy a ticket to watch that game. So I think it's really important that we that all of us work together with that as well.
Yeah, and considering this, so what would you say we are going in the future in terms of, again, managing in a qualitative way the risk of our athletes with the target of reducing the number of injuries? So on what we should concentrate more our efforts for the future?
You just mentioned it, the athlete's voice, the coach's voice, bringing them into the conversation, understanding what's the important factors for them. If you say, hey, Nicol, your risk of tearing your hamstring in the 100-meter finals in the Olympics has gone up to 90% now. We're almost certain you'll tear your hamstring. Now, I don't know of an elite athlete in the world that won't say, hey, man, I'll take that chance. Is there still a 1% chance I finish the race and win? I'll take it, right? But we are also advocates for their long-term health. And so, I mean, you yourself know the devastating effects some of these injuries can have on your long-term health and well-being. And so we also have to help our athletes understand what are the consequences long-term of that. So that's important that we perform those roles, but in the context of performance. And then making sure that they are driving that they are driving the process, that the athlete makes these decisions with us supporting them. And so my favorite analogy at the moment is if we think about the weather forecasts. Now, there's an 80% chance of rain tomorrow. I probably take my umbrella, right? So I trust the weather forecast enough. So if it doesn't rain tomorrow, I'm usually not that mad that I have my umbrella with me, right? I'm just glad it didn't rain. If there's a 20% chance of rain, I probably don't take my umbrella. I kind of say, oh, you know what, it probably won't rain. And if it then does rain, I'm okay with that too, because I knew the risk I was taking was low. And if it happens, so be it. So in both those scenarios, you have completely different outcomes, and you've made completely different decisions, but you're satisfied with the results to some degree, at least, right? I mean, we're never happy when we're getting in the rain, but we're happy with the process. We I think we should aim to get to, and we only do that if we include the athletes, the coaches, the management in our decision making, and we have the data to understand what the weight of the evidence is suggesting. So I hope that that's the kind of result we'll see to really drive ownership, leadership, and shared decision making in this process.
So to conclude, I would say tell me if you agree with this. I think you do, because I know you a bit now, but anyway, so it's rather a continuous job. It's rather, what we do every day to make sure that we include all the potential and possible risks in our everyday job with our athletes, rather than running behind a problem when we have a red flag that is flying in the sky, right? Oh my God, this is too late, so I have to do something. It's actually making sure that we can minimize the risks and long term, so during the year. And then if we monitor athlete in a proper way, we can have maybe a yellow flag in terms of being not red. Just a parallelism with flags in differential diagnosis is not the perfect one, but you know what I mean. Do you agree? So it's again back to do a qualitative job during the year and the entire time, rather than running when it's too late and screaming all around.
Well, so one of the other researchers that have done a lot of work around the space is Cherie Becker, and Cherie likes to say it's complex, not complicated, right? And there's a difference. So complicated is, in her example, building a rocket ship to fly to the moon. Complex is raising a child, for instance, right? So I think there's a difference, and we have to appreciate the complexity that sometimes have simple solutions. We have to measure what matters, right? So make sure that when you're dealing with your athletes, you have stuff that you can measure, that to be sure that the change you see is real. And then I think listen to your patients, listen to your athletes. They have intuitive feelings about what's happening with them, and if we pay enough attention, we might actually help them in a better way.
Last question. What have you been experiencing in terms of working with other professions? So I would say doctors, athletic trainers. We know that working with people such as strength and conditioning experts or certified SNC certified and AT athletic trainers is maybe easier because they do appreciate this. They knew it already. But maybe with medical doctors can be a little bit more challenging in terms of introducing the need of risk management and also then doing something. So have you faced challenges in terms of the communication with them? Okay, we have to actually implement new stuff. We never did it before, but it might be worth. And I cannot prove it now, but I will be able to prove it in 1 or 2 years, because this is in the end another part of our job. If you work in a team, maybe not as such a professional team, but maybe a small team, you also as a physio have to propose ideas and convince people. And maybe usually the doctor is in charge. There is someone as a doctor is in charge. So few advices might be useful for sport physios that works not in major teams, I think.
I think I've been lucky and exposed to amazing professionals throughout my career who have really been open and inviting in these processes. So some of the great sports and exercise medicine physicians at Aspetar over here in Ireland and back home in South Africa. So, but I would say, if you're honest and vulnerable yourself, so I'm but strong about what the skills you can bring, I think that really adds value. And everybody, it might take time to get there, but everybody will eventually experience that. This is our different lanes. They overlap, but I can count on my colleagues' experience. In that sense, I think it's really about relationships. We underestimate that maybe sometimes in our own world, but we still need to build relationships. We need to trust each other, and in that sense, leadership plays a really important role as well. I really like the idea of a horizontal management system, but then at times we really need leaders to kind of float up and perform that leadership role. Like, for instance, at the moment, there's loads of challenges about the health of our professional athletes. So we need our doctors to perform that, right? I mean, I'm really happy to submit authority to them in that sense. And then if we're talking about ramping up the training to get them ready to compete, got to understand from an athletic performance point of view what that means, right? I mean, that's really important. So from an injury risk rehabilitation monitoring point of view, I think we can then add value to that conversation. So I think if we give out the respect and build the relationship that we desire, I really do believe that people will be responsive to that in the end. But it's a dynamic situation, and I think it's changing for the better.
Yeah, I love what you said, because this is weird, never happened before, but we are kind of linking to different Nova talks. We had just published a Nova talk with Chad Cook from Duke University, and there was a moment in which we talked about building relationships with surgeons. It wasn't in relation to injury prevention or minimizing risk of injuries, but anyway, sometimes in our profession we just work with patients, and we don't reach out for surgeons. And maybe we tried once, it wasn't such a positive experience, might happen, it's life, and then we sort of give up. But this is so crucial in terms of bonding with other professionals, and then being respected and respect them as well, because obviously, as you correctly said, now is historically speaking, is a moment in which, it's not a physio call, right? I mean, we need doctors to tell us what we have to do. We need epidemiologists. We need experts in that specific field. So bonding and creating relationships, it's so crucial to then, at the moment of doing something, being able to have a solid base to act, right?
Absolutely. And then, like, if we use our current situation, so from a health perspective, it's also important to be active and to understand how you can stay physically active. So then the physios and the athletic trainers play a role there, and how to make sure we're minimizing I think it's really a collective process, and I think Chad nails it. It's about building relationships and understanding the desires, the needs of our colleagues. I mean, that's really also important to ultimately serve our athletes. I think that's the big thing. We're all here for the same reason. We're all here to help patients recover, to make them better, and to help them perform. So if we keep that in mind, I think it will help for us all to bury the egos a little bit and to work towards a common goal.
Absolutely. So thank you. That was great chatting with you on this topic that you clearly are an expert on. And then obviously now it's a weird period, as we commented before. We will see how things will evolve. It will take time, but we're looking forward to have you back in Italy and in other countries with NovaVia. But thank you for this. I think people will appreciate this Nova talk online soon.
Thanks for having me, Seb. Appreciate it.
Okay, guys, so I hope you appreciate that. That was Nicol Van Dyk talking about injury prevention or risk management for with the goal of minimizing injuries. Thank you, and see you soon around.
Thank you.